Now it's my pleasure to introduce the first session in the COLDA meeting. This session will be about prevention of transmission, looking after mother and child. And it's my pleasure to introduce the first speaker. Dr. Maud Limwan is a reader and honorary consultant in hepatology at St. Mary's Hospital, Imperial College in London since 2011. She's been working with the Medical Research Council, the Gambia unit, as part of the Prolifica program, which is prevention of liver fibrosis and cancer in Africa. And this program is in the Gambia and Senegal. She's been a member of WHO Guideline Development Group for the Management of Chronic Hepatitis B and C, and is regularly commissioned by WHO Viral Hepatitis Unit for external reviews and consultancies. And the title of the presentation will be Birth Dose Vaccination and Screening of Pregnant Women. Maud?
Thank you very much for your invitation. I am very pleased to take part today of this very important discussion on hepatitis B birth dose vaccination and maternal screening for hepatitis B in Africa. As you all know, viral hepatitis B is highly endemic in resource-limited countries, and Africa accounts for about 60 million people chronically infected with the virus. In resource-limited countries, HBV is transmitted early in life, either from mother-to-child transmission, called vertical transmission, or between children later in life, called horizontal transmission. High maternal HBV viral load, often associated with positive HBe antigen, is the key driver of vertical transmission. In Africa, vertical transmission is less frequent than in Asia as compared to horizontal transmission. We believe that vertical transmission accounts for about 10 to 15% of the transmission of hepatitis B in Africa. And this is one of the reasons why vertical transmission of hepatitis B has been long neglected in Africa. However, even in Africa, it's extremely important to prevent HBV mother-to-child transmission for four main reasons. First, the earlier the virus is transmitted, the higher the risk of chronicity is. And secondly, as part of the Prolifica program, we have shown that the early transmission of HBV is associated with higher risk of liver complication. In other words, people infected with HBV from mother to child are at significant higher risk of liver fibrosis, cirrhosis, and HCC as compared to people contaminated later in life during childhood. Thirdly, our research group at Imperial College London has shown that more HBV transmission will be due to mother-to-child transmission worldwide. Indeed, infant vaccination scale-up will mean that in the future, a greater proportion of new cases will be observed among neonates, as you can see here in blue as compared to the yellow curve. And importantly, our research group at Imperial College London has shown as well that to achieve the WHO HBV elimination target, it is absolutely critical to control HBV mother-to-child transmission. Indeed, as you can see here in the orange curve, even if we scale up HBV vaccination to 90%, it will take years and years to achieve HBV elimination. But if we combine HBV vaccination scale-up and prevention of mother-to-child transmission, then we can achieve the HBV elimination by 2030. But as I just told you, HBV mother-to-child transmission has been long neglected in Africa. And one of my colleagues, Dr. Shimakawa, has even shown that in Africa, the number of newborns infected each year by HBV is twice higher than the number of newborns infected with HIV each year. So how to prevent HBV mother-to-child transmission? So since 1992, the WHO recommends universal infant vaccination. And this means 3 doses of the vaccine at the age of 8 weeks, 12 weeks, and 16 weeks. And this has been integrated within the API of most African countries. Since 2009, the WHO recommends the birth dose vaccination, which means the administration of the first dose of the vaccine within the 24 hours of birth to all newborns born in high endemic areas. However, the delivery of HBV birth dose vaccine is a real challenge, especially in resource-limited countries. So the global coverage is only 39%. It's 35% in Southeast Asia, but as you can see, it's much lower in Africa, estimated at 11%. To date, only 12 countries have implemented the HBV birth dose vaccine in sub-Saharan Africa. A recent systematic review and meta-analysis even estimated a lower coverage of hepatitis B birth dose vaccination, with an estimate at 1.3% in sub-Saharan Africa. So why this? There are many barriers to hepatitis B birth dose delivery. First, this poses many logistical issues. There is still a high proportion of births at home or in non-medical facilities, with a lack of outreach programs to cover the births outside the hospital. The delivery of the birth dose vaccine is also a challenge over the weekend, and the birth dose vaccination also requires a cold chain system, which is not really available in all remote and rural areas. There are also diverse sociocultural barriers, and for example, in some countries there is no trust in the healthcare systems, with familial pressure to give birth at home rather than the hospital. The healthcare workers are not well educated enough on the importance of delivering the hepatitis B birth dose vaccination. And there are also a combination of political and financial issues. The Global Alliance for Vaccination and Immunization still does not provide the monovalent hepatitis B vaccine in Africa. So how can we improve the hepatitis B birth dose vaccine coverage? We could use a controlled temperature change strategies. This team from Australia has shown that using this system could really be cost effective and impact on the HBV related burden of disease. We could use a pre-filled, very friendly device called Uniject, pre-filled with the vaccine. And that could be used by, for example, community health workers to reach babies born in rural areas at home, for example. There is some microneedle patches of vaccines under development, but still not available. Probably developing more outreach community programs would be a good strategy to improve the HBV birth dose vaccine coverage. And improving education is absolutely critical. A study has shown that the poor awareness of the healthcare workers was associated with poor hepatitis B birth dose coverage, irrespective of the vaccine costs. However, what we know is the hepatitis B birth dose vaccination is not sufficient to control HBV mother-to-child transmission. In Africa, HBV mother-to-child transmission has been poorly documented, We know, but only from one non-randomized control trial, that the efficacy of the hepatitis B burst dose vaccine is good, but not sufficient to prevent the transmission. And in babies born to high viremic pregnant women, there is a residual risk of transmission estimated at about 38%. So if we look at the Asian triple model intervention, you are certainly aware of these two randomized controlled trials from Asia. They both have shown the excellent efficacy of the triple model, combining maternal antiviral therapy using tenofovir in high viremic pregnant women, combined to the delivery of the HBV burst dose vaccine in their babies, plus the HBV immunoglobulins. However, this triple model is not applicable in sub-Saharan Africa for different reasons. First, there is no routine antenatal HBV screening in Africa. The risk stratification based on viral load levels or HBV antigen seropositivity is extremely difficult to run in sub-Saharan Africa. First, to run an HBV DNA measurement, it's complex, expensive, it is not done in routine in Africa, and even doing a HBE antigen serology is not always easy in rural areas. And there are currently 3 point-of-care tests which have been developed for the HBE antigen, but the sensitivity is very low. And thirdly, there is almost no access to HBV immunoglobulins, which are very expensive and again requires a cold chain system. And finally, and that is absolutely critical, there is no evidence-based data for the use of antiviral therapy in pregnant women in Africa. So how to control HBV mother-to-child transmission in Africa? There are different options which probably need to be better evaluated, but it is certainly urgent to implement HBV screening alongside, why not, the HIV and syphilis antenatal services. We have rapid point-of-care tests for HBs antigen, which are very accurate and not expensive. Regarding the risk stratification, the use of the HBE antigen point-of-care test is probably not an ideal good answer, since they have a poor accuracy with a sensitivity estimated between 30 and 40%. The use of dry blood spots could be an answer. We could run HBV DNA using dry blood spot, or use the gene expert system, which has been really important for Africa. However, these gene expert systems are not available in remote and rural areas. So some groups have also proposed to treat all intervention, treatment as prevention, as it is done for the prevention of HIV, mother-to-child transmission, without doing any risk stratification. This has been proposed to be a cost-effective strategy in South Africa, for example. But again, all these strategies need to be evaluated in Africa. So to conclude, prevention of HBV mother-to-child transmission is critical to control the HBV epidemic. And even if mother-to-child transmission is less important in Africa than in Asia, it is associated with a high risk of liver complication. So it is extremely important to control HBV mother-to-child transmission even in Africa. We urgently need strategies that are adapted to the African resource-limited settings to improve the HBV burst dose vaccine coverage, but also to control HBV mother-to-child transmission and eliminate finally the virus. So we need to develop strategies to improve screen and treatment intervention for HBV infected pregnant women. So I would like to thank all my colleagues from all over the world, especially from the Gambia and Senegal and all the partners of the Prolifica program. And I invite you to follow us on Twitter and Facebook and to visit our website. And thank you.
Thank you, Maud, for this excellent presentation. And now it's my honor and pleasure to introduce my dear friend, Dr. Philippa Easterbrook from WHO Switzerland. She will present on the WHO prevention of mother-to-child transmission of hepatitis B recommendations. Dr. Easterbrook is Senior Scientist in Global Hepatitis Program, HIV Department at the WHO headquarters in Geneva. She's an HIV and infectious disease physician and epidemiologist who has worked in the UK, United States, and Sub-Saharan Africa. At WHO, she has led the development and dissemination of global normative guidance for HIV as well as hepatitis B and C testing and treatment.
Thank you very much for that introduction, Manal, and thank you to the COLDA Organizing Committee and the excellent virology education team for the opportunity to contribute to this session. So my presentation will be in 3 parts. First, a brief summary of the 2016 WHO Global Hepatitis Strategy and Targets that's provided the roadmap towards elimination, and to summarize what our progress to date has been in meeting those targets with a focus on the Hepatitis B MTCT. Second, to orientate you to the WHO PMTCT guidelines on the use of antiviral prophylaxis that was launched on World Hepatitis Day at the end of July, in terms of the rationale for this new guidance, the new recommendations, and a summary of the evidence base. And thirdly, to discuss briefly some of the feasibility challenges, implementation considerations for implementing these recommendations, and to touch on the opportunities with triple elimination and the recent development of elimination criteria at WHO, as well as touching on the impact of COVID. So Maud has already covered this in her excellent presentation in terms of the epidemiology, that we have more than 250 million people currently living with chronic hepatitis B infection, with around 900,000 deaths per year, with the highest burden and prevalence in the WHO African and Western Pacific region. Worldwide, the most common routes of transmission are the mother-to-child vertical, as well as the horizontal early childhood transmission that account for most of the chronic infections as summarized by Maud. And therefore, the focus to prevent is the most important way to control the Hep.B epidemic is to prevent these infections, both mother-to-child and early transmission. Unfortunately, we have a highly effective vaccine. And shown at the top here is the WHO estimates of what the global hepatitis B surface antigen prevalence in children younger than 5 years was before the widespread adoption of universal infant vaccination from the 1980s to the early 2000s, with a prevalence of 4.7%, and in 2017 down to, in fact, 1.3%. So this is really a great public health success story. Well, in 2016, countries endorsed the first ever global health sector strategy for viral hepatitis, calling for the elimination of viral hepatitis as a public health threat by 2030, defined as a 90% reduction of new infections among children 5 years of age for hepatitis B by 2030, and a 65% reduction in deaths, with 5 core interventions, both prevention as well as testing and treatment. And the red bar highlights the PMTCT interventions with the infant vaccination, 3 doses, and also the birth dose and the use of other measures, with a target for a 90% coverage for the 3 dose of the infant vaccination, 90% for the birth dose. This slide shows where we were at as of 2015, which we have established as our baseline, and that's shown in the dark bars, the dark horizontal bars for each of those various service delivery coverage interventions, and the light bars showing what the 2030 targets were. And you can see at a glance that the Hep.B vaccination we're really doing well on, much less so on the use of birth dose and other PMTCT measures. And then the other striking gap is really the testing coverage and the associated treatment coverage for those who are eligible. But there's good news. There's good news in as much as we are on track to achieve the 2020 target of the 90% coverage with the third dose of the Hep.B vaccine. And as of 2018, coverage of the 3 doses of the vaccine reached 84% worldwide, compared to around 30% in 2000. But the coverage of the birth dose remains much lower and uneven. So for example, the coverage of the birth dose is 42% globally, but only 4% in the African region. So still many challenges ahead. But as a result of these decades of progressive scale up of the third dose of the Hep.B infant vaccination, we have now achieved the 2020 global target of less than 1% Hep.B surface antigen prevalence in 5-year-olds. And this was based on a systematic review and modeling work undertaken by John Edmonds and his team at the London School. And you can see here by region the prevalence rates, and overall a 0.84 94% prevalence among 5-year-olds, and all regions achieving less than 1% other than the Afro region, which is still at 2.53%. So I've highlighted progress and some of the successes. In addition to the reduction in prevalence in 5-year-olds, there's also been a substantial reduction in the drugs and diagnostics. Tenofovir is generally available for $25 to $30 per year. There's no longer any patent in any country, and generics are widely available. And there has finally now started to be a reduction in the molecular, the viral load tests, both for hepatitis C and hepatitis B, with costs now reducing in many areas to less than $15. Still, we have some way to go with hepatitis B. There's been more progress with hepatitis C. And although 5 million, more than 5 million as of 2018 were receiving Hep B treatment, this still falls far short of, given that we have 257 or so people living with chronic hepatitis B infection, and many remain undiagnosed. So there has been evolving WHO guidance. It's already been mentioned about the WHO recommendations for that all infants should receive a first dose of Hep B vaccine as soon as possible after birth, preferably within 24 hours, followed by 2 to 3 doses to complete the primary series. And in 2015, in the Hep B guidance, there was recommendations for who to treat. That the use of tenofovir in those with cirrhosis, or in the absence of cirrhosis, those with a raised Hep B DNA greater than 20,000 and raised liver enzymes. On that occasion, we did not make a recommendation for use of antivirals in 2015. And this was largely because of, at that time, the limited and low quality evidence base, with still several ongoing clinical trials that were due to report. The limited comparison for different antivirals. There was only one observational study for data with tenofovir, and a lack of consensus as to the programmatic implications of a policy of more widespread antiviral use in pregnancy with limited access to viral load. Following those guidelines, also there was the testing guidelines on viral hepatitis, as well as the consolidated guidelines on HIV testing, recommending that all pregnant women should be tested for HIV, syphilis, and hepatitis B at least once and as early as possible. So the main reasons for these new WHO guidelines on the use of antivirals was because of the new evidence now emerging for trials, that there were now increasing requests from regions and countries in the context of plans for triple elimination of HIV, syphilis, and hepatitis B for mother-to-child transmission. And also concerns that timely birth dose alone, together with the infant vaccination schedule, may not be sufficient to reach the elimination goals of 0.1% prevalence in children under the age of 5. And so the vision and the hierarchy of interventions, just to so that the new recommendations can be positioned within this hierarchy, is that clearly scaling up access to a timely birth dose is the most important and cost-effective option for preventing infection. But in those countries in particular that have already achieved high vaccine coverage, and so a reduction in horizontal transmission, mother-to-child transmission accounts for a high proportion. And in these settings, routine testing among pregnant women and offering tenofovir prophylaxis for those eligible is really an important additional opportunity, together with HBV as well in those settings. So the new WHO guidelines have two key recommendations. First, in addition to the series of Hep.B vaccination, that's the first dose within 24 hours, as well as the 2 to 3 additional doses, WHO now recommends that pregnant women testing who are Hep.B surface antigen positive with a hepatitis B DNA equal or greater than 200,000 international units per mil receive tenofovir prophylaxis from the 28th week of pregnancy until at least birth. And that was a conditional recommendation based on moderate quality of evidence. Secondly, in settings where hepatitis B DNA testing is not available at antenatal sites, WHO also recommended the use of Hep.B antigen as an alternative test to determine eligibility for prophylaxis to prevent mother-to-child transmission. And thirdly, that it would also be important as a rider that all the pregnant women should first be assessed for eligibility for long-term antiviral treatment based on their own health needs before initiation of prophylaxis, as addressed in the 2015 guidelines. And this is a simplified algorithm that captures the assessment of the pregnant woman, both for who's Hep.B surface antigen positive, both for her own health needs in terms of eligibility for long-term prophylaxis, or whether, and this is in the pink box, whether she fulfills the criteria for starting antiviral prophylaxis, with, of course, reassessment subsequently as to whether long-term treatment may be necessary. And this is all on the foundation of the Hep.B birth dose vaccination, infant vaccination, and the use of HBV if available. So what is the evidence to support these recommendations? Well, the evidence base was from systematic reviews, impact and cost effectiveness modeling, an overall assessment of the benefits and harms and the balance of the benefits and harms at both an individual and population level, and patient and health worker values and preferences, as well as resource use. So this slide summarizes the systematic review undertaken by Yasuki Shimakawa and his team at the Institut Pasteur. And this was an evaluation of the efficacy and safety of peripartum antiviral prophylaxis. There were around 129 studies, 33 randomized trials, based on 18,000 women. And of note, there were only 7 studies outside China, so the vast majority were in China. And none of the studies evaluated the efficacy of antivirals without HBV. So in other words, with birth dose alone. And this slide shows well the impressive result demonstrating the substantial protective effect with a odds ratio of around 0.17. The second systematic review was addressing the question of identifying the viral load threshold in HB infected pregnant women, above which the risk of immunoprophylaxis failure increases. And this shows, it's slightly off center here, based on 66 studies, showing that the risk of transmission increases above 200,000 IU per mil. And finally, addressing the question of the alternate use of the E antigen to identify those with a high viral load based on the hepatitis B DNA, as well as address the question of how well the E antigen test predicts immunoprophylaxis failure. And the conclusion was to the first question, that the overall pooled sensitivity for diagnosing a high viral load was 88% and specificity 93%. And overall, the E antigen has a high sensitivity but lower specificity for predicting the risk of mother-to-child transmission. And as has been highlighted already by Maud, now turning to the modeling away from the systematic reviews, that really the evidence showed, and Maud showed a magnified version of this, that birth dose scale up really has the largest incremental impact on the new chronic infections, taking it down to this lower bar, but the final lower bar is the use of antiviral prophylaxis with screening in pregnant women. And in terms of the issue of feasibility and patient and health worker response, we undertook an online consultation as part of the guidelines process. 153 healthcare workers, 56 program managers, and 81 civil society representatives. And around 3/4 felt it was feasible to provide testing and offer tenofovir prophylaxis to eligible pregnant women, but the challenges highlighted were those of the high cost and availability of HBV viral load, the inadequate training of healthcare workers, limited knowledge about HIV among those living with hepatitis B infection, and lack of capacity and infrastructure. So clearly these are issues that need to be addressed to ensure full implementation. So in terms of implementation, how feasible will it be to implement these recommendations? Well, I think there is reassurance, certainly from the experience for the elimination of mother-to-child transmission of HIV and syphilis, that providing testing for pregnant women followed by antiviral prophylaxis for those with HIV is feasible. And as of the end of 2018, about 80% of pregnant women globally knew their HIV status, and 82% of those tested positive for HIV received treatment. But the same is, of course, not yet true for syphilis or hepatitis B. And clearly, different geographic regions are faced with different scenarios with respect to the prevalence of hepatitis B, service coverage of immunization, including birth dose, the availability of commodities, particularly diagnostics, as well as antivirals. And so the implementation of the recommendations will vary by region. So in high endemicity regions, such as the African region, where there is currently suboptimal coverage of infant Hep.B vaccination, really the priority is, of course, increasing coverage of timely birth dose to achieve the greatest impact. Whereas in low endemicity countries with already high coverage of infant vaccination and birth dose or targeted birth dose, peripartum tenofovir prophylaxis in those high-risk populations with high Hep.B DNA would prevent further perinatal transmission. And I think an important consideration going forward will be access to hepatitis B DNA and the existing infrastructure that is already available, be it high throughput or point of care platforms such as GeneXpert. And a really important opportunity going forward is the opportunity to advance the Hep.B MTCT agenda as part of triple elimination. So triple elimination, an initiative that promotes the elimination of mother-to-child transmission of 3 infections that have some common routes of transmission, common approaches to testing and service delivery in an antenatal setting, and are highly prevalent in low and middle income countries. And really advancing the agenda to provide integrated patient-centered care within the context of antenatal. And of course, many regions, or at least 3 regions within the WHO geographic regions, had already been pursuing the dual elimination of HIV and syphilis, and there was already momentum for the addition of Hep.B MTCT. And so 2 regions in particular started 2016 and 17, that's the region of the Americas and also the Western Pacific region, and now the Sero region as well, have triple elimination plans and a framework for elimination. And we have also now been actively moving ahead with the development of validation criteria for the elimination of viral hepatitis, and held our first meeting at the end of June, focusing on Hep.B MTCT. And have moved forward with some early steps with development of impact criteria, as well as the program service delivery criteria, and with the vision to develop something similar to the HIV syphilis path to elimination for those countries that are still some way off reaching elimination, with a gold, silver, and bronze category in order to motivate and incentivize countries to progress on the path to elimination. I think we will be returning this in the discussion, and Maud has already alluded to this, of really addressing what measures are needed to improve hepatitis B coverage. And of course, the impact of COVID on all this, with staff repurposed, MCH services impacted, both provision of services, uptake of services, as well as access to HIV, hepatitis, and STI services for testing and ongoing treatment. And some modeling work from Imperial College for World Hepatitis Day demonstrated well the impact of if vaccination scale up is disrupted in 2020, such that coverage drops by 20% for infant and 60% for birth dose. This could result in an additional 630,000 chronic infections and 130,000 HBV-related deaths among children born in 2020. So these are initial models demonstrating the impact of disruption in services. And this is a major focus at WHO, is really ensuring re-establishing and maintaining essential health services. So final slide that should be the acknowledgements. I'd just like to acknowledge the many people that contributed to these guidelines and to the evidence generation. And just to flag from some of the slides I showed, Judith Van Hulten, who undertook the values and preferences, Morgan Newman leading on the HIV PMCT, and Shalini Desai from WHO on the immunization, and Yasuki Shimakawa for the systematic review, and Shivanti Nayagam and Tim Hallett for the modeling. Thank you very much.